Hi everybody, and welcome to the Thursday edition of Video Clips, and we've moved on from our very lengthy discussion of the book Whole onto some other topics, and one that I'm really excited about is finally, long overdue, members of the cancer establishment are starting to question diagnostic testing for cancer, the definition of cancer, and which types of cancer we should be treating versus leaving alone. As I mentioned, it is long overdue. So new recommendations or guidelines came from a National Cancer Institute committee. They were published in the Journal of the American Medical Association. Now, we can expect, and already I've seen this in a lot of online blogs, there are going to be some people that are really resistant to any of the changes that this group is proposing, and others who are saying it's about time. One, Dr. Otis Brawley, who's the Chief Medical Officer for the American Cancer Society, said, quote, "We need a 21st century definition of cancer instead of the 19th century definition, which is what we've been using." Now, the report starts by stating that during the last 30 years, screening is focused on the idea that if we diagnose cancer at its very earliest stages, that we will reduce the risk of someone developing late-stage cancer and dying from cancer. But that actually hasn't worked. Instead, there has been a huge increase in the diagnosis of early-stage disease, but not a proportional decrease in the number of late-stage diagnoses, and not a real reduction in the death rate from cancer. And the reason for this is that cancer, and I'm using that term in its broadest sense here, can follow multiple paths, not all of which lead to progression and mortality. And the problem is we treat everybody, regardless of which flavor they have. Non-aggressive could die with it but not of it, versus something very aggressive. We sort of treat everybody the same. Medicine doesn't really differentiate much between the two. So what we see, for example, is that when we're talking about screening for breast and prostate cancer, lung cancer, Barrett's esophagus, and melanoma, is that lots of screening going on, lots of early stage lesions being detected, but no reduction really in the detection of late stage disease and mortality from these cancers. It's really only with colon cancer and cervical cancer that we've seen a real reduction of mortality rates. So part of the problem is if you look at our current screening programs, they're very, very good at detecting early stage disease that may not progress to anything, and not very good at detecting aggressive cancers, which are the ones that kill people. Those are the ones that we have to pay attention to. So, and there is a growing consensus that maybe some of these early stage lesions, or whatever we call them, shouldn't even be labeled cancer. So ideally, if we had a perfect system, cancer screening would focus on the detection of cancers that ultimately harm people. And since our current screening programs don't do this, the article suggests that we need better methods. And of course, I would add quickly to that, we ought to just stop doing some of this stuff until we have a better method. So the article makes a few important points which I want to share with you. One is that physicians, patients, and the general public have got to recognize that overdiagnosis is very common and it occurs with cancer screening. So overdiagnosis means detecting a meaningless condition, really, which is common, again, in the breast, lung, prostate, and thyroid. And by acknowledging the consequences of this screening, we can look at different approaches to mitigate the problem. So overdiagnosis is common, it's an issue, we should all know about it. The use of the term cancer should be reserved for lumps, lesions, growths, tumors that actually are a threat to a person's health. And we should be very careful about screening methods that identify these harmless lesions, such as ductal carcinoma in situ, because if that's what they're good at detecting, they're really good at resulting in patients getting over treatment. Mitigating overdiagnosis, and they suggest several strategies for this. Reducing the frequency of screening examinations, focusing screening on high-risk populations, raising the thresholds for recall and biopsy, and testing the safety and efficacy of risk-based screening approaches to improve selection of patients for cancer screening. And I know that this is well-intentioned, but unfortunately, the way that humans are wired, they really can't be told that we've detected something, it's, you know, it's a lesion, we're not so sure about it, you know, just don't worry about it, go home and live your life. I think what we really need to do is teach people to stay away from this type of screening. But again, I don't want to dampen anybody's enthusiasm for the fact that this is such a step in the right direction. expand the concept of how to approach cancer progression. And this goes to a couple of discussions I've had lately with physician friends where there is a movement that maybe we should be looking at certain types of cancer as chronic conditions to be managed and controlling the environment, looking at, for example, could diet control the progression of cancer and do a better job than treatment or surgical approaches. Terminology really does matter. You know, Dr. Gilbert Welch in his book, Should I Get Tested for Cancer? Maybe Not, and Here's Why. He talks about the diagnosis of pseudo-cancer. It's really not cancer. Well, you still have cancer in the name, and that's an issue, but he would say that, he does say in his book, that a lot of these lesions they just should be left alone. You'd probably be a whole lot better off if you didn't even know that you had it. And right along with the idea that terminology matters, the World Health Organization started changing the terminology for cervical intraepithelial neoplasia. They took out the term malignancy that's usually associated with it. And what they found is when you change the name of a cancer type diagnosis and you take cancer out of the title for it or name for it, that people become much more willing to do watchful waiting than when the name cancer or malignancy or something of that nature is associated with it. So anyway, this is an encouraging first step and what I'm sure will be a very long, hard road to change. I mean, changing anything in the medical field is difficult. And of course, the diagnosis and treatment of cancer is a multi-billion-dollar industry in this country. These people are not going to give it up easily. But I'll tell you what really is good. Back in the days when this kind of thing just got published in the Journal of the American Medical Association and was read by a few doctors, not much would happen. But this was on the front page of the New York Times. It's getting a lot of attention in medical blogs and consumer publications and health websites and that kind of thing. And so I think that consumers are starting to read this type of thing. And I've always said what we need to do is to teach consumers to walk into a doctor's office and just say no to diagnostic testing and supplements and drugs and procedures and all this stuff that doesn't really help very much. But all in all, a great step in the right direction. And you know, the National Institutes of Health is not known for being the most forward-thinking group on these kinds of issues. So for them to sanction a committee issuing this type of report, pretty amazing day in America, I think. So anyway, that's all for now. As usual, pass this on to anybody who you think would enjoy watching it, and I will be back to you again next week.